During my internship in abdominal surgery, I was told that we should never leave appendicitis unoperated before the sun goes down. I think the same is probably also true for mitral regurgitation. Of course, we have a bit more time than one day. But there's one big threat.
This threat to patients with severe MR is irreversible left ventricular dysfunction. We have to operate the patients before the left ventricle deteriorates. Even though in theory it seems easy, in reality it is not. The symptoms of the patient are very unreliable at times. The quantification of ejection fraction is difficult, especially in the range where we have to decide if it's normal or maybe mildly reduced. And the intervals between the visits are crucial, because it can happen that you see a patient, he has normal ejection fraction, the next time you see him, left ventricular function has already deteriorated. This diagram shows you a specific problem in patients with chronic MR. Left ventricular function tends to deteriorate after surgery. Why is that so? Well, before surgery we have an unloaded left ventricle. Remember, we have a reduction in afterload. After the operation, after we close the hole of regurgitation, left ventricular function deteriorates because now the left ventricle has to carry a higher afterload. Remember this pump? And you remember the hole which represents mitral regurgitation? Well, after operation, the hole is gone. What will happen? Well, you have to apply much more pressure, even though the pump is now much more efficient. So coming back to this diagram, take a look at patients who have an ejection fraction which is normal at operation, and what happens to some of these patients after operation. Well, after operation they have an ejection fraction which is way below normal. So the lesson from this diagram is we have to operate the patients as long as they are supranormal. In addition, a poor ejection fraction at operation also means a poor survival. Take a look at patients who have an ejection fraction of below 40 at operation and see what happens. Compare those with patients who have an ejection fraction which is above 50%. So again, a very important indication that we have to operate the patients before left ventricular function deteriorates. Another important lesson that we have learned is that it is better to repair the valve than to replace the valve. Why is that so? Well, simply because with valve replacement we also damage the subvalvular structures, and they also play an important role in the contractile process. In addition, if we replace the valve or if we repair the valve, it is important to preserve the chordal structures as far as possible. But the surgeons already know that. So, summing up, what are the indications for surgery? First of all, if you have patients who are symptomatic. So, no matter if the patient has a reduction in left ventricular function or a normal ejection fraction, if he is symptomatic, he needs operation. In asymptomatic patients, there's a long discussion as to who should be operated, but what is crystal clear is that patients who have an ejection fraction below 60,
An end systolic diameter above 45, patients with new atrial fibrillation,
or who show signs of pulmonary hypertension, in other words, a systolic pulmonary pressure above 50 millimeters mercury, should undergo surgery. So back to the question, should asymptomatic patients with severe MR be operated? Well, actually a very difficult topic. As a matter of fact, there's been a fierce battle within the medical community discussing the pros and cons. Some say every patient with severe MR should be operated. Others say watchful waiting is just as good. What is my personal approach? Well, I think the truth lies somewhere in the middle. You can use a strategy of watchful waiting in asymptomatic patients and just monitor them for function and size with echo, and the intervals where you see the patient should get smaller the more you have the feeling that they're starting to have a problem if the ventricle starts to get larger from one exam to the next. Another thing which is important is pulmonary pressure, because I think pulmonary pressure is maybe more objective than the symptoms. If you're in doubt, use other tests, for example stress test, or if you want to really know how left ventricular function is, you can also perform MR scan, for example. If the patient has a high likelihood for repair or for successful repair, and if the patient is also willing to undergo surgery and you know that the surgeon is good, then you can also use the strategy of earlier surgery as well. And finally, another issue to consider, what about patients with low ejection fraction? Remember, they deteriorate further after surgery because we have an elevation of afterload after surgery. Is there cutoff value? Yes, there is. The cutoff value is 30%. Below 30%, you should not operate these patients. Other treatment strategies for these patients, conservative management, in other words, heart failure treatment, and transplantation. In clinical practice, the problem is the assessment of ejection fraction. Remember how difficult it is to quantify ejection fraction? So it will always be a discussion, is he above or below 30%? And is there maybe still a chance that we can operate him? Well, again, you have to use your individual judgment and maybe other tests as well to come to a final conclusion. These image clips are from a young patient with moderate to severe MR, not based on a structural problem of the mitral valve, but on restriction of the posterior leaflet. Why? Because he had inferior infarct. You see the scar here and also here in the basal inferior septum, and also look at the direction of the jet. Well, the question now is, should you operate him? Well, basically, there is no clear-cut indication for surgery in the setting of ischemic heart disease, for MR. However, in this patient, bypass surgery was also required. So in him, we also performed reconstruction of the mitral valve with annuloplasty, and he benefited greatly even though his left ventricular function is very poor. So again, you have to be very individual with respect to your indication for surgery, and you have to look at it on a patient-to-patient basis.
So I hope this chapter showed you how difficult it actually is to manage patients with MR and to determine when surgery should be performed. Maybe in the future we'll have other techniques, better diagnostics, which will help us to say, okay, this is the point in time where we should really go to surgery. Still, personally I believe the decision will always be an individual one.